My name is Liz Reynolds, and I'm with Biodesics. On today's webinar, we're going to be highlighting two different technologies that are impacting the diagnostic landscape of nodules. To do that, we have Dr. Sonali Sethi from Cleveland Clinic, who is going to give a presentation on the clinical and economic benefits of efficiently diagnosing lung cancer. Dr. Sethi is an interventional pulmonologist and the director of Cleveland Clinic's Lung Cancer Diagnosis and Staging Program. She also serves as the program director for Interventional Pulmonology Fellowship and Procedural Training at Cleveland Clinic. She's a well-respected thought leader within the biomarker space in pulmonology, and I'm honored to turn things over to her now. Dr. Sethi, go ahead.
Thank you, Liz. I appreciate that. Good evening, everyone, and thank you for giving us your time. For some of you, I know this is dinner time, and we appreciate you joining us. So the goals of what I want to talk about today are we're going to discuss the incidence of lung nodules, which you guys are all aware of, and some of the metrics, but I specifically want to focus on the workflows that are associated with the time a lung nodule is found at CT chest imaging to the actual evaluation of that lung nodule. We're going to talk about some of the best practices that are out there for lung nodule clinics. I'll give you some insights about what we do here at the Cleveland Clinic. And then I would like to focus a little bit of time on risk calculators. This is one of my favorite things I like to talk about. I think it's underutilized, and that's probably mostly because people don't truly understand risk calculators that well. I'm going to then talk about biomarkers and how we incorporate that into our practice and how it could be helpful. And then when you decide that you finally do want to take a patient to bronchoscopy and it's necessary to go ahead and diagnose that lung nodule, hopefully with the lung cancer that you're concerned about the next generation robots that are out there that now have image integration with the robot. And I think that this puts this robotic platform above and beyond what the other robotic platforms have to offer. And we will discuss a little bit about that. So you can see that technology as well. So you guys are all aware of this data. There are approximately 1.57 million nodules that are found in the United States annually. And it always is surprising to me the minority of these nodules that get actually a workup done. Only about 36% of lung nodules will eventually end up going some type of workup. And so there are patients walking around out there who have lung nodules. The majority of them are going to be benign, as we're aware. However, we are concerned about those that are malignant and would love to be able to pick up on those early. There are limitations to these nodules and why we don't detect them early. And the reason for that is the majority of these nodules are found incidentally. So as you are all aware, lung cancer screening isn't quite where we hoped it would be. We're all doing our best to try to get that process better. However, these are patients walking into an emergency room or they're having some abdominal CAT scan done and you happen to get the base of it done or some cardiology CAT scan done. And hopefully, if these scans are done, the radiologist will read it and the person who ordered the scan will pick up on this nodule and then they will follow it up or refer them to the appropriate physician to follow it up. However, most of these patients get lost to follow up. And a lot of reasons exist. There's variables in risk factors in the population. There's not the feeling of that ownership of this disease, and you do have to have that relationship with these different specialties. And then there's workflows that need to take place that we'll talk a little bit about. How do the incidental nodules get to you? How are they getting referred to you? Who's doing the follow-up? What are the platforms that we're using to be able to follow up these nodules? So lung nodule management programs, whether they are actually formalized or not, are beginning they're beginning to form, I think, more successfully. But in order to make this successful, the first thing we need to do is we need to discuss who's finding these lung nodules, where are they coming from, and who is flagging them. There needs to be some kind of risk stratification and triage that's happening. How are they being assessed for the risk of malignancy, and what treatment plans are these patients a candidate for? Then there needs to be shared decision-making that takes place. Patients and providers need to sit down together. You need to discuss what are the next best steps for the patient. And then there needs to be some kind of intervention and follow-up. What plan is this patient going to go through? Sorry, I'm trying to advance. So there's a fine balance between lung cancer surveillance and when it's time to intervene. So 95% of the lung nodules that we find are benign. We know that the majority of these nodules are benign. However, we don't want to miss the nodules that are malignant. We want to be able to intervene in a timely manner. And the reason for that is we know that the overall survival in these patients goes down as the nodule increases in size. I love using this diagram here because I always get asked by patients, what is the size of this nodule that I have? And generally I'll tell them if it's about a centimeter, it's the size of a Cheerio. If it's about 2 centimeters, it's the size of a penny. And if it's 3 centimeters, it's going to be the size of a slice of a banana. However, we don't want to be taking patients to the Bronx suite where these nodules are benign. And the reason for that is there's a higher cost. It's been found to be 28 times of a higher cost for patients with a benign diagnosis when they're actually going through a biopsy. Um, so we want to reduce the number of unnecessary procedures on these patients. So what we want to do is improve the time and efficiency from lung nodule detection to lung nodule diagnosis. And there are best practices that are in place, and we're going to go through each of these in great detail. But there's nodule recognition. So there's two different methods that nodules can get found. It's either with your incidental program or your lung cancer screening program. For some places, it may just be one program. We actually have these defined into two separate programs. And then you need to know once these nodules are detected, how are they going to get followed? There's manual tracking and there's software solutions that could help you out. Believe it or not, we do both of these. Our incidental nodule actually is manually tracked, and our lung cancer screening program has software solution packages that are in place that do cost money. So as a workflow, you need to decide what's going to work best for each of these programs that you're putting together. Lung nodule navigators are very important, and I'll go into a little bit more with you about why this is important and how you should go to your hospital administrations and try to get these navigators, whether it be a nurse, whether it be an APP, whether it be a physician, whatever it may be. It is necessary to get these navigators in place. There's also patient clinical evaluation, and this is where we're going to talk about lung nodule calculators and biomarkers and how they can come into play. And then there's diagnostic efficiency. Once the patient is found to have this nodule and you're going to take them to the Bronx suite, we're specifically going to talk about the Galaxy system and how you're going to get a diagnosis on this nodule. And then you always have to have great communication with your thoracic surgery and oncology departments. So let's start with lung nodule recognition. So these referrals will come in various manners. Here at the Cleveland Clinic, what happens with us is this: most of our incidental lung nodules get flagged at the time of radiology. So the radiologist sees a CAT scan, they flag this nodule, and then through Epic, it goes into a pool. And then we actually have an APP who manages these incidental lung nodules and then tries to outreach to our patients at least 3 attempts to try to get the patient in to one of our lung nodule clinics so that these patients can get evaluated early. So you need to come up with some kind of workflow. This could be using manual spreadsheets like I just explained, or you could have software solutions. So our lung cancer screening population, I told you, actually has software solutions in place. We use the Eon software. It does help quite a bit. It helps with the follow-up. It helps reaching out to patients when they're due for their follow-up scans. And it helps collect a lot of data that you can utilize later on when you're looking at your programs and how to evaluate things. When we're looking at the lung nodule navigator themselves, they actually are the point of contact for your patient. And so they are an integral person or part of a lung nodule program that you're going to have. They're a resource. And they are the ones that are going to reach out to patients. They're going to attempt to get them into clinics. They're going to call them with their lung cancer screening reminders. They're going to give them guidance. And in return, we need to give them real-time guidance back as well when there are difficult nodules to manage. So they need to be able to have nodules that are more problematic discussed. What we do is once a week here, we actually have a lung nodule board, a multidisciplinary board that meets where all of our APPs who are part of our lung nodule clinic will come, and there will be 2 or 3 physicians, and nodules get presented there that are difficult, and we come up with a consensus. It's kind of very similar to what your multidisciplinary tumor boards would be. And we come up with a consensus on how to manage those nodules. There needs to be a real-time review and a process in place for these worrisome nodules, and they need to be able to reach out to someone and schedule bronchoscopies. The way we do that here is we have a bronch scheduling pool, or what's called an e-consult, where if it's a nodule that is felt that needs to be biopsied, it will go into an e-consult, and then one of the interventional pulmonologists here will review that request that comes in, decide what is the appropriate platform, and then the bronchoscopy will get scheduled. And we try to get that bronch. Our goal is to get that bronch scheduled within 7 days from the time of the referral to us. And then there has to be the post-diagnostic follow-up. And they actually take ownership of these patients. They're the ones who do the follow-up. So let's say it's me who's doing the bronch. I'll reach back out to them. I will discuss treatment plans with them if they need any guidance or offer to help them in whatever way they need in reaching back out to these patients. But they are the communicator with the patient and their sole navigator through this entire process of getting a diagnosis of lung cancer. Risk factors. We're all aware of the risk factors of lung nodules, right? The size obviously matters. Larger nodules have a higher risk. The shape of it, is it smooth? Is it round? Is it spiculated? Is it growing? The patient history. You need to spend time in your clinic visit with the patient to assess the history. The location of the nodules. Obviously, the majority of nodules that we see are in the more commonly in the upper lobes. The number of nodules that you're seeing, are you worried about metastasis, or could these be infectious or inflammatory nodules? The pattern of the nodule, associated features, cavitary changes very much can be infection, but we also need to keep in mind that cavitary nodules can also be malignancy. And most of these patients are asymptomatic. And then there's risk models that you can put into play in conjunction with all of these risk factors that you're looking at when you're doing a history on these patients. So I'm going to go a little bit into lung nodule calculators so you guys can get an understanding of this. There are many different calculators that are out there. The Mayo Clinic model, I'm going to go into a little bit more detail because this is one of the more common calculators that is out there. It's highly validated. It's widely applicable. It is the one that we use here for the majority of our patients at the clinic. However, there are some drawbacks to this model, and I will go into that in a little bit. There's also the Brock model. This actually has the benefit of being used in screening populations, and I'll tell you why in a second about that. Also has some drawbacks that it can overestimate patients that are never smokers. There's a Herder model, just so you're aware of this, not used as frequently, but this can enhance accuracy with PET scans. So it includes PET scan imaging in it. However, a drawback is it's limited if you do not have that PET scan. There's the Gurney model. This actually is an ideal one that could be used for cavitary nodules. There's the VA model. I'll touch on this a little bit because some of you may be from VAs, and this might be the better risk calculator for you to use. And then there's the BIMC model, and this is one that really considers cavitation and growth. But again, the two most common calculators that are used out there, that if you talk to people who have incorporated these into their lung nodule clinics and practices, it's mostly the Mayo Clinic model and the Brock model, and I will go into these in a little bit more detail. So let's start with the Mayo Clinic model. This is one of the most frequently used probability models and is the most extremely validated model that is out there. It's built on a retrospective review of 629 medical records. And these were nodules that were discovered on chest radiographs that measured anywhere from 4 to 30 millimeters in size. They looked at 6 clinical and 8 radiographic characteristics, and it's some of the things that we just discussed are really important when you're looking at lung nodules. So they can take into consideration the age, if you're a smoker or not. Do you have a prior history of cancer? What is the size of it? Is it spiculated? And where is it located? The strengths of this is that it includes a wide range of malignancy probabilities. So it includes never smokers and heavy smokers. However, it does not include PET. It does not include growth rate or history of cancer within 5 years, and it was built off of chest radiographic features. So this is probably one of the most common risk calculators that is used and is a fairly good calculator for incidental lung nodules that get found. The Brock model, or the McWilliams, was developed from the Pan-Canadian Early Detection Lung Cancer Study. This one included 1,871 lung cancer screening participants with over 7,000 nodules. The strength of this one is that it includes multiple pulmonary nodules, with lung nodules having different nodule attenuations. So it includes nodules that are solid, part solid, or GGO. These were noted or discovered on low-dose CT scans, and it included a lot of the same things the Mayo Risk Calculator includes. But in addition, they included a family history of lung cancer. Did you have emphysema? Again, that nodule type or attenuation. The number of nodules were counted as well. So the strength of this calculator is that it includes the multiple pulmonary nodules I talked about. It has the nodule attenuation. However, it did not include non-smokers, and the size of the nodules could be very large. It was, or in fact, you're in mass range, but it's 1 to 86 millimeters. In a screening setting, this is probably the best risk calculator to use when you're looking at that particular patient population, because that is the patient population this was validated on. For those of you at the VA centers, this VA model calculator was actually built from data from the Department of Veterans Affairs. These were lung nodules that varied in size from 7 to 30 millimeters and were found in veterans. These were primarily people who were men, patients that were men. They were significantly older. They were all mostly smokers, so the prevalence of malignancy in this population was very high. It was 54% prevalence of malignancy. They looked at 4 independent predictors. So they looked at smoking history, the patient's age, the nodule size, and the time since you stopped smoking. The strengths of this risk calculator is it's very helpful in this high-risk population, specifically a VA hospital or VA clinics, and this may be the risk calculator that you decide to incorporate into your practice if that happens to be your clinic setting. So looking at the 2 most common risk calculators that are out there, the Mayo Clinic model is one of the most frequently used probability models I told you. It includes lung nodules discovered on chest x-rays that measured 4 to 30 millimeters, and the strength is it includes a wide range of malignancy probabilities. It includes never smokers and heavy smokers, and this is with the prevalence of cancer of 23%. Again, a great risk calculator to use in the incidental population. The Brock model or McWilliams model was developed from the Pan-Canadian Early Detection of Lung Cancer Study. The strength is that it includes multiple pulmonary nodules as well as solid, part solid, or GGOs. Prevalence of lung cancer in this population was 5.5%. However, you need to keep in mind it did not include non-smokers, and therefore you may overestimate the probability in never smokers. So what are the problems with these lung nodules when they come in? So this is a typical patient that comes into your clinic. I actually happen to be in histobelt, so I have very limited things that help me in deciding what to do next. Specifically, PET scans are not very helpful for me because PET scans are going to light up in histo. And so this is a typical patient that I might be seeing in my clinic that comes in, a 70-year-old smoker. I've got this 10.2 millimeter nodule that's sitting here. It's solid. It is kind of smooth and round. I don't have spiculated borders. It's hard for me to tell. Is this malignant or is this benign? If I plug this into the Mayo risk calculator, the risk of malignancy in this case is 34%. So it's not low and it's not high enough. I'm right in that intermediate risk group where, I'm still in that what do I do kind of phase. This nodule actually ended up being benign after 2 years of follow-up. So when we actually look at our data, we know that the majority of the nodules that we're seeing in our clinic are benign. Yet 62% of biopsies are being performed on benign nodules. These are nodules that are 8 to 20 millimeters in size. And 35% of surgeries are being performed on benign nodules. Again, 8 to 20 millimeters in size. This is a lot of patients undergoing procedures that were unnecessary. On the flip side, 17% of patients go on to at least 1 round of CT surveillance before they get diagnosed with lung cancer. And we actually want to be able to catch those patients earlier. So it would be really helpful if there was something that could help us not go in and do unnecessary procedures on benign nodules and help us not delay diagnosis in patients who actually do have lung cancers. And this is where blood-based biomarkers come into place. Specifically, we're going to be talking about Notify Lung. So Notify Lung is a risk assessment which integrates two different tests or platforms. There is the Notify CDT and the Notify XL2. These are two high-performing blood-based tests that have been extensively studied and published on. These are rule in and rule out tests. So Notify CDT is a rule in test. It's a blood-based autoantibody test that tells you what is the chance of a nodule being malignant. The Notify XL2 is a rule out test. It is a blood-based protein assay that helps determine whether a lung nodule is benign. And so again, a rule-in test, Notify CDT, and a rule-out test, Notify XL2, are very helpful in integrating into our practices to help us determine what is this nodule that we're looking at? Is it benign or is it malignant? And helping me to decide what is the next test that I'm going to be doing on these patients. So the testing is intended for patients who fit the following criteria. You need to be 40 years or older. You need to have a lung nodule that's 8 to 30 millimeters in diameter. So you're in that intermediate risk category. And your pretest risk of malignancy should be less than 65%. The pretest risk calculator that gets used in this particular test is the Mayo risk calculator that we went through in detail. It was not validated on patients who have a previous diagnosis of cancer, so you should not have a previous diagnosis of lung cancer. And you are eligible, though, if you had non-lung cancer greater than 5 years ago and the risk of malignancy is less than 50%. So again, let's start with the Notify CDT, which is the rule-in test. This is it measures 7 autoantibodies in all stages and types of cancer. So the cancer can be non-small cell stage lung cancer, or it could be small cell. The 7 autoantibodies that you see here are listed on the right-hand side, and you can see that when we look at this particular test, it's a high-level test result with a 98% specificity and a 78% positive predictive value. A 98% specificity means that there's a 2% false positive rate. That means 2% of benign nodules will receive a positive test result. That means this test is performing pretty well. A 78% positive predictive value means that 4 out of 5 positive results are going to actually be cancer when you get a positive result on your CDT. So in the Notify XL2, this was the protein, the 2 proteins we talked about. This was developed by evaluating 388 proteins that they started with, and I don't know how they refined this down, but they refined this down to 2 single proteins for clinical use. And this test was designed to integrate molecular markers with a physician assessment of nodule risk to be a rule-out test to tell you what is the chance of that nodule being benign. So when we look at clinical practice and early experience, what we have been able to find is if you look at this curve, what this does is it shows you the number of patients that are in that intermediate risk group. So on the left-hand side, that gray curve that you see are all the patients that got tested that are in that intermediate risk group of lung nodules. And what this test does is the rule-in, so the XL2 will upregulate you 5% of the time. So out of all of those patients that you test, 5% of the time, you're actually going to move up into the high risk category. And 35% of the time with the rule out test, the XL2, you're going to downregulate into the low category of lung nodule risk. So you're taking all these patients that are in this intermediate risk and you're kind of pulling it out into pushing some of them into the high risk and some of them into the low risk. And you can see nicely in this graph how this does this. So recently, Pritchett presented at CHEST 2022, and what he wanted to do was he wanted to look at this test specifically, if it could be used in both incidentally found lung nodules as well as screen detected lung nodules. And as you can see on the left-hand side here, you can see the sensitivity and specificity was equivalent between the incidental and the screen detected group. So the test or the performance of Notify XL2 did not differ between the incidentally identified and the screen detected nodules. Again, the test showed that you were able to take a lot of those patients and you were able to down-regulate them, actually up greater than about 50%. They found it was even more than what the national data had found, that when they looked at this in this particular study, that they actually had more nodules that were getting down-regulated into that low-risk group. So what that means is these nodules are not having unnecessary procedures done on them at that point in time. This again is the national data of this is the most recent graph that is out there that they shared with me. And what you can see here is that there's about 35.3 thousand, 0.3K patients that have been tested so far. And you can see how many of these patients have been downregulated, which is about 39%, have been down-regulated and gone into CT surveillance out of that intermediate risk group down into that low risk group. To give you an example of how this test gets utilized, this was one of my own patients. This is a Notify CDT case, actually. This was a 64-year-old patient who had a 10-millimeter nodule in the right upper lobe. This was a current smoker, had no prior history of cancer, and this patient was not comfortable moving forward with the procedure. Despite us having a conversation, they just weren't comfortable moving forward with the procedure. The Notify CDT study was done on this, and the pretest risk of malignancy when this was put into the Mayo risk calculator was 39%. In this case, I don't generally get PET scans, but a PET scan was done, and the SUV on this was 3.3%, and the Notify lung test was ordered. And the CDT result came back within 24 hours and actually showed a high risk of malignancy. Because of this, I spoke to the patient and we were able to come up with a consensus that this nodule now is probably high risk of malignancy. I was very concerned about it. The patient did end up going for a VATS resection. And in fact, this was found to be a stage 1A adenosquamous carcinoma. So very helpful in this situation. This may have been a patient that would have been put into CT surveillance. It was a patient that was hesitating moving forward, and this was definitely a test result that allowed me to have a better discussion with my patient about what the next steps were for this patient. On the other hand, this actually is a Notify XL2 case. This is actually not a case that I sent. Actually, my thoracic surgeon sent this. These are results that we do discuss with at our thoracic tumor boards as well. But this was a 66-year-old female non-smoker who had a history of obesity, had OSA, a lot of other issues going on, respiratory muscle weakness, and was found to have this left upper lobe lung nodule on imaging. It was an 11 by 8 millimeter spiculated nodule. And this was new when it was compared to their last CAT scan, which had been 1.5 years early. Also had a PET scan with uptake on it. It was read very suspicious for primary lung cancer. After an interdisciplinary discussion, I was not part of this discussion, but this patient went for a VATS with a biopsy, and this turned out actually to be non-necrotizing granulomas consistent with histo. After that, the patient did have some complications. They had post-op dyspnea, and this was multifactorial. It was due to pain and splinting and got an infection. And the thoracic surgeon was actually very smart and actually wanted to see if we had sent off an XL2 on this, what would the result have been? Kind of wanting to test the test, but also seeing could we have saved this patient from an unnecessary procedure. And when the XL2 did get sent after the case, it was found that the result of this came back 2%, and we may have been able to save this patient from going through this procedure with all the post-op complications that they had. So the Notify lung testing strategy is designed to help get the most out of both of these tests. That's the rule-in test and the rule-out test. So again, the rule-in test is the Notify CDT. It upregulates patients about 5% of the time, so it allows you to be more aggressive in that patient population when you're going from that intermediate risk group into a high risk group, meaning the chance of that nodule being malignant is greater than 65%. And it downregulates patients into a low risk 35% of the time. So you are comfortable going into a CT surveillance or following up that nodule. You never stop following a patient based on these test results. You can do a modified Fleischner guideline, which is what I tend to do. So if I'm in the low percentage, I'm in the 1 to 2% chance of that nodule being malignant. I do a modified Fleischner where I may not get the next follow-up scan at 3 months. I probably would wait a little bit longer, but I do continue to do the CT surveillance up until 2 years of time. However, I'm getting less scans for those patients. What about, I did talk about invasive procedures, and this test probably could reduce the number of invasive procedures that we're doing. And in fact, that is true. Pritchett also was able to show us this study as well. And what he found was that by addifying Nodify XL2, we were able to reduce the number of procedures that were happening on benign nodules. He found there was a reduction in procedures actually from 51% to 26%, which means you're not taking patients unnecessarily to the bronch suite anymore. And this allows you to actually take more patients into the bronch suite and get a diagnosis of cancer. So you're doing more appropriate bronchoscopies on patients that absolutely need to have those procedures done. Since we're talking about doing procedures, we'll now move on to intermediate to high risk nodules and how do we get a diagnosis on these patients and what do we have at our disposal to be able to get a diagnosis on these patients. So I spoke about this before. We don't want to delay getting a diagnosis. We know the longer we wait to get a diagnosis, the worse these patients do. And overall, we do also know that we generally can get patients into a bronch suite a lot quicker than we can get them for CT guided biopsies. At least that's true here at the Cleveland Clinic for us. And the time of referral to us getting in for a bronch is rather quick. I told you we wanted to try to get patients in within 7 days, but we also want to try to get our patients' time to treatment to be to be 21 days. Overall, the country national data shows that this on average is about 41 days. Here we shoot for a 21-day mark that we want to try to move the patients along quickly. It has been shown that if you're going to go for a CT guided biopsy, on average, you're adding about an additional 11 days. So you're talking about 22 days now to get your biopsy, and then you add that 41 days again to get their treatment, and you can see how you're delaying time to surgical treatment on these patients. And, you know, I love this data down on the bottom that shows that it actually does matter when you get these patients into the operating room, because if you can do your resection within or less than 60 days, their 5-year survival is actually much better than if their surgeries are delayed from the time of them getting in to get their surgeries. This graph again is just showing that the time to diagnosis matters, and it really does impact your survival. And it doesn't matter if this is stage 1 or stage 2. It affects in all stages of lung cancer. So you want to be able to diagnose these patients, and the time to treatment initiation clearly matters in these patients. So you want to be able to diagnose these patients early and get them moving on their way. With regards to us diagnosing these lung nodules, so back in 2004, that's when these navigation platforms first started coming out. It was quite an exciting time for us. Superdimension came out and got clearance. We all got on board with that. We all had diagnostic yields which were better than what we were doing before, all about in the 70th percentile. And then we had about this 10-year lag, and the diagnostic yield needle really didn't move too much. So for about 10 years, we accepted this yield of about 70%. This was the best that we had. And then in 2020, that's when the first robot came out, and we were expecting things to significantly improve with these robots that came out. And we found with these first generation robots, and I'll show some of the data, we did get slightly better. However, we were still again in that 70th to 80th percentile mark, and that's kind of where we've been sitting for the past couple of years. So this is the Monarch data, so that when they first came out, you can see here the various publications that have come out, and there were some good studies here. There were some good prospective multi-center studies here, but you can see that despite these robots coming out, the diagnostic yield again sitting in the 70th percentile. Complication rates did not go up whatsoever. We proved that as well with these robots. And so the next first generation robots that came out, this is without integrated imaging. Again, you can see here that diagnostic yield sitting at about 70 to 80 percentile without any integrated imaging in the various publications that came out. So, when robotics were coming out, like I said, we were very excited about this. We knew that it was going to it was going to help us improve to reach the outer periphery of the lung where most of these nodules were. It was going to give us the stability that these lung catheters weren't giving us, that moved every time we put a tool in it. It was going to stay stable. And we were hoping that it was going to reduce our CT to body divergence to improve our biopsy success, because it wasn't going to move. And so our tools were now going to stay in place. So you weren't going to have a catheter that suddenly moved when a needle went in it, and you got that CT to body divergence. These first generation robots that came out did an excellent job of reaching further. We know that. We did get the scope tip stability that we were hoping for. However, we very quickly started to learn we didn't overcome the CT to body divergence as well as we thought we were going to. So we did with some aspects of tools, but we found that we still weren't quite there. And that's when the question came up of, would imaging help us get to the next step? And this is where first generation robots then started incorporating either mobile 3D systems or cone beam CT systems, fixed cone beam CTs. And we, in fact, did prove that imaging matters. So the scope will get us to where we need to go. It will keep us in place. However, the last 5 minutes of the procedure, the most important thing we can do is all imaging. It's imaging related. And that is what is now getting our diagnostic yields up into the lower 90th percentile. But in order to do this, you need to have access to a mobile CT, cone beam CT, or have a fixed cone beam CT system, which is not something that is an easy task for most institutions or for most of us to be able to get our hands on. And that is where the Galaxy system came in. They very early on understood the importance of imaging. And so what they did, and I would like to call this the next generation of robots that came out, this is the newest one that came out on the market, is they came up with this tilt technology and augmented fluoroscopy. And tilt technology is tool and lesion tomography technology. With your normal 2D C-arm, so any regular C-arm that you have in your bronch suite can get used with this particular robot. In addition to having the tool and lesion tomography, which I'm going to show you, it actually also has augmented fluoroscopy. And this allows you to have a confirmed tool and lesion, where you actually see your tool and lesion. So all those nodules now that you have that are not detectable, 8 millimeter nodules, ground glass lesions, whatever it may be, up on a fluoro screen you can't see, it's now telling you exactly where it is on your fluoro screen, and it's telling you exactly where you need to biopsy. And this is what we need, and this is what we've been missing to be able to overcome that last part of CT to body divergence that we weren't able to overcome up until now. Some of the other pluses of this particular robot, it's got a single-use disposable bronchoscope, so it's got simple setup and cleanup. You plug the scope in, you throw it away. You've got continuous visualization the entire time. So you don't get to a nodule. It's quite frustrating. Sometimes a lot of these nodules out in the periphery are right in the airway. You get to the nodule and then you have to take out the camera and you have no vision. You have continued vision throughout the case. And so again, it's a disposable bronchoscope, and the platform, the footprint of this is smaller than the other scope, so it doesn't take up a lot of room. And the setup and cleanup, if you guys were to ever trial this, is very, very easy in the room. So I want to go into particularly the tilt technology, which is the tool and lesion technology. So what you do is you take the robotic arm, You navigate out to about within 3 centimeters, and people even at 4 centimeters will do this. And then you take your fluoroscopy machine, you spin it around, and I'll show you this workflow in a second. You spin it around, and then what you do is you get an updated location of the nodule. You then get an augmented fluoro image on your screen, and then you know exactly where you need to biopsy, and then you'll get a tool and lesion confirmation. You'll actually see your tool in the lesion. And I think that is where the diagnostic yield has been coming from. It's because you actually have that tool and lesion confirmation. So this is the workflow of that tilt technology. So you take your bronchoscope, like I said, you get close to the lesion, and then you take whatever fluoro arm you have in your bronch suite, and you do a 60-degree sweep. That's 30 to 30 from LAO to RAO. You then mark the tip of the scope. You scroll through, you find the nodule. I'm going to show you some images on what that looks like. You mark the nodule. It updates where the nodule is. And then here, that blue circle that you see is the augmented fluoroscopy image that you get. You know exactly where that nodule is on your screen. You know exactly where your tool needs to go. You get true targeting that you're going to see on these images. I'm going to start with the study. I'm going to go through my data, and then I'm going to show you some actual cases. So this is a frontier study. This was done in Australia. This was the first in-human trial, and I want to say that I'm quite impressed with the Australian group because they had never done any navigation before. They did not have the privilege of having Super D machines. They had done no navigation before. This is the first technology that they ever had in their hands. They were given this robot, and then data was being collected from case one. Just to see how they did with it. And you can see that they 100% had successful navigation with this technology. They demonstrated tool and lesion 100% of the time. And look at their diagnostic yield here right off the bat, which shows you the learning curve is not that much. Like I said, they were great bronchoscopists, but they had never had navigation platforms that they had to practice on. And here they were able to show that their diagnostic yield was 90 to 94%. The average nodule size they had was 20 millimeters. They weren't going after lung masses. They were going after conservative sized nodules here. This is our own data at the Cleveland Clinic. It is it's old now. We have a lot more cases now, but at the time this slide was made, we had 51 cases completed. You can see our average procedure time was about 46 minutes. This has gotten even less now as we've done more cases. We've been able to have 100% tilt confirmation. That means we see that tool and lesion confirmation 100% of the time. Our diagnostic yield on these 51 cases has been 92 to 96%. And the final yield, the reason it's 92 to 96 is that case needs to be followed up with a 2-year follow-up or 1-year follow-up really to see if it's actually going to remain the diagnosis that it has. And the one big thing I've noticed that's been a change in my own practice is I no longer have to use radial EBUS because the tool and lesion confirmation for me is the radial EBUS. I don't need to put a probe out there. A lot of times the probe isn't even helpful when the lesion is far away from the airway and you need to throw a needle out or forceps out and you're not even near it. It hasn't been as helpful to me, and it took me some time before I realized this and stopped relying on it. I just want to go over very quickly, I'm going to breeze through this, what the benefits are of a single-use bronchoscope. So there's workflow efficiencies regarding the reprocessing. You don't need to reprocess these scopes. Repair maintenance costs go down. You don't get fatigue and drift from these scopes. What this means is by the time you're using scopes, continuously, they get jagged inside, right? And so you have trouble getting tools through them. They don't quite make it through the number of times that they're supposed to be utilized. You're not going to have that with this. And there's removal of cross-contamination with the single-use bronchoscope. There's reduction in expenses because of this. There's less water that's being used. And again, you're saving money on those reprocessing costs. Because of all of this, there's now been the TPT eligible reimbursement code that's come out that I'm sure you're all hearing about. This is one of the hottest topics that's out there. This was recently approved by CMS, and this qualifies for any Medicare patient in outpatient settings in which this code can be used. This Galaxy scope, because it is a single-use scope, does qualify for the TPT coding, so it is eligible for reimbursement. So if you submit this code, you will get paid back on that. So just quickly, I'm going to go through some cases here. This was a case of a right lower lobe nodule. This was one of our first cases in a 64-year-old female with scleroderma, 100-pack-year smoking history. This was a nodule that was found on admission for pneumonia. This tree is actually flipped, but what I wanted to show you is how nice the segmented tree looks and your pathway. This is your planning software. When you're looking at your pathway to get to the nodule, you can have various pathways to be able to get to a nodule, but you also realize the pathway doesn't matter as much anymore when you've got that tilt technology and augmented fluoro, so you don't need to focus on this quite as much. And you can see here that this is the lesion, and on the left in that coronal view, what I want to show you is how nice this lesion actually looks and how great the imaging looks here compared to your CT scan imaging. And then here you can see your tool and lesion. This is your confirmation that the tool is actually in the lesion. You have the needle, it's in the nodule, and you're sitting here and you can see your needle in the actual nodule here. So this is, again, the augmented fluoro. You can see the augmented fluoro image here, the circle and the needle coming into the lesion. And this was a patient who had adenocarcinoma on rows that was consistent with breast primary. Here's another case. This was a left lower lobe lesion. Again, I just really want to point out how nice the imaging is here that you get on your tilt technology compared to your CAT scan. This is actually during the procedure. You can see how when the forceps is about to come out, you may be about to miss the actual lesion here, but then you can readjust when you're in your targeting mode to be able to readjust to get your tool into the augmented fluoro target that you want to actually get it into. And for time's sake, I'll just move through here. And here again, you can nicely see on the fluoro image your tool actually in that augmented fluoro imaging, and you're actually in it. That is your tool and lesion confirmation. One last case I'm going to share, and then we'll take a Q&A here. This was a 76-year-old patient with a prior history of COPD, had a history of lung cancer, bladder cancer, and B-cell lymphoma, who came in with this left upper lobe nodule 6 months prior. And it did grow to 7 by 6 millimeters and got referred for a biopsy and could have a diagnosis of any one of those things. This could be a new lung cancer, it could be a recurrence, it could be bladder cancer, it could be the B-cell lymphoma. Again, what I want to show here is you can see how nicely you can see that nodule on your tilt imaging. Again, this is with your regular fluoro. This is not your mobile cone beam imaging that you're seeing. This is your regular fluoroscopy machine that you're seeing. You can see the nodule here. This is compared to your CAT scan imaging. And as you're spinning around, you can see you make that image nice and crisp. And then you will go into your target, the nodule gets updated. And then you're going to go into your targeting mode where you're going to actually have your augmented fluoro image here. You're going to have your target, you're going to have your view, and you're actually going to see your tool go in the lesion. What I wanted to show here is as you spin around from LAO to RAO, you can see in every plane, you are still in that target. That means you are definitely in it. You're going to get a diagnosis. And here again, diagnostic on rows, it was an adenocarcinoma. So I hope that we were able to go through lung nodule management with you in a multi-step approach. I hope I was able to give you some solutions with some things that you could incorporate into your own practice. I hope that you were able to see the value of risk calculators and of biomarkers and how to incorporate that in your practice and how it could help you decide whether a nodule is actually benign or malignant, and maybe move nodules into that 5% malignant or move them down into that 35% of the time into that benign risk group category, out of that intermediate risk group category, and then show you when you have to go to the bronch suite how important imaging is, and specifically this robot that has tilt imaging and augmented fluoroscopy as part of it, and I hope you can see the benefits that this robot has to offer over the other robots in helping you to be able to get a diagnosis.